Mr. Chairman, distinguished guests, it's my great honor to be here for this presentation. On behalf of Iranian Heart Association, I'd like to express my sincere gratitude to GIS organizing committee hosting this outstanding scientific program. Thank you. My name is Bahram Mohebbi, interventional cardiologist. The title is One Vessel, Two Stories, because he has actually two problems. 40-year-old male with headache and hypertension, history of hypertension. There is a discrepancy between arm and leg hypertension. EKG sinus rate associated with LVH. Echocardiography, normal LV size, normal ejection fraction, 3 cuts with AV, but significant coarctation of aorta adjacent to left subclavian artery with peak gradient about 50 millimeter mercury. Aortic CT angiography. You see, there is significant narrowing after subclavian artery, but the other part of the aorta is significantly dilated. That's why I consider it as one vessel, two story. Significant narrowing associated with significant dilation. And if you want to have a look at the short axis of it, you see, descending thoracic aorta is significantly dilated. So we have a case of descending thoracic aneurysm associated with coarctation. And as you see, the distance of the coarctation was about 15 millimeter. About 20 millimeter, 2 centimeter is borderline. So, surgery versus endovascular. Which one? Since we have encountered a thoracic aortic aneurysm, so TVAR is standard of care with descending thoracic aneurysm. Because we have lower periprocedural complication versus open surgery, especially regarding spinal cord ischemia, which is a little bit higher in surgical correction of descending thoracic aorta, and also comparable long-term survival. I need to add patient tendency to this one, which the patient wants not to have open cardiac surgery. So we consider TVAR plus coarctation stenting. First of all, checking access vessel, because patient is a case of coarctation of aorta, so lower limb arteries may be underdeveloped. Fortunately, access vessel is good. We had another access from the right arm as a control, and as you see, here is the minimum diameter of coarctation, not here, and it's very narrow, associated with dilation of aorta. And as you see, this is a type 3 aortic arc, which make passage of any device very difficult. We were not able to advance the wire retrogradely, so we tried to advance it antegradely. Again, it was a tough job, but thank God, finally, we advanced the wire. Snare the wire from the lower extremity, externalize it, finally try to advance the TVAR stent. It was a very tough job to advancing it due to type 3 aortic arc. This is the size of the device. This is a control injection to actually consider where should we deploy it. You know, control deployment is a key element in this procedure. So we try to deploy it. Again, as I mentioned, control deployment is so important. After releasing two parts of the stent, again, we inject to check the position, releasing the other part, the remaining part, and then opening the nose cone, I mean the apical cap here. And it is, again, under the pressure and associated with significant gradient still. Another problem was that when we try to pull back the delivery, it was not possible. Actually, the delivery was stuck over there. So we tried to advance the sheet to capture the delivery. It means that there is significant narrowing at the coarctation of aorta. Finally, we advanced the sheet, captured the delivery, and then pull back the delivery. This is a control injection, and as you see, there is significant narrowing at the site of the coarctation. So since this was associated with significant pressure gradient, we try to put a balloon expandable stent here to cope with this significant narrowing. As you see, T-bar stent does not have significant radial force. So we try it first, and then since it was not possible to cope with the gradient, we try a balloon expandable stent, I mean a stent in a stent. As you see, yeah. Never try to ameliorate this sound over completely. A little bit residual remaining is enough, no pressure gradient at that time, okay? That's why we consider it. This is control ejection. Now the gradient has decreased. We have another problem because the dilation was continued whole thoracic descending aorta, so we need to put another stent because actually the thoracic descending aorta was dilated up to diaphragm level, even up to the upper part of the celiac artery. So put another stent, check the location, SMA and celiac artery, unsheath the device, releasing the distal part. Now the gradient has ameliorated. Subclavian is patent. No significant gradient is here. No extravasation. And the celiac is open. Follow-up CT angiography after 6 months show that there is no endoleak. The stent is completely opposed. And this is a VRT which revealed that here, site of coarctation and a stenting up to the celiac artery. So, sometimes coarctation can be complicated by developing descending thoracic aorta. Incidence is about 20%. Sometimes we consider it as just post-stenotic dilation. If it advances, it may result in aneurysm. Excessive wall stress could be the reason of this problem. And coexisting coarctation and descending aortic aneurysm increase the risk for aortic rupture. There are some technical considerations in combined T1 and coarctation staging. So precise measurement of landing zone is mandatory. Our landing zone was borderline. It was just about 18 millimeter. We need at least 20 millimeter. Oversizing T1 should be a little bit conservative when coarctation is associated with aortic aneurysm. And avoid aggressive pre and post dilation. That's why I consider never try to ameliorate hourglass completely, because it may increase the risk of rupture. And control deployment, I mean, when you are releasing the device, try to have an injection to check the location before releasing it irreversibly. Spinal cord protection is important. In this case, we had a stented long distance of the aorta with 2 stents. It's very important. Although subclavian artery was patent, but we need to focus on the spinal cord ischemia. Try to keep the mean arterial pressure about 90/30 and consider CSF drainage just in case. So as a take-home message, adult coarctation could be associated, and the key point in this one, in this case is, if you consider to do that, please consider that control releasing device is very important, and never try to ameliorate the narrowing completely. The gradient will decrease. Thank you for your attention.